Thank you. Just real quick before we jump in, I just want to say thank you to everybody who put together the poster session last night. I thought it was phenomenal. I've been in and out of lots of different conferences, and it was a really great opportunity to network and have conversations about our project. So for those of you guys who didn't come and chat with us that had questions, hopefully this will help answer some questions. We had no disclosures, just a little bit of background about our facility because it really plays into some of the barriers and obstacles that we met. It's a 703-bed facility. We do have a dedicated cardiovascular institute within that. We have, within the CVI, the Cardiovascular Institute area, it's broken into two sections, a medical CVI and a surgical CVI. Our surgical CVI has two dedicated ICUs, a PCU, and our OR suites include two hybrid ORs, a dedicated PACU, and a pre-surgical testing. I didn't put that up there. We have two different physician groups, and this is definitely one of the things that created some challenges for us. We serve the Carilion employed physician group of the Aortic Center, and then we also have an independent group, Jefferson Surgical Clinic, that has 4 physicians that do surgeries. That changed? Yep. Okay, so we established our registry in 2012. We had a lot of inconsistency with our data collection. Inconsistencies just came from a lot of access issues and being able to view charts. Again, with us having a private practice that was doing surgeries, they had a completely different EMR, so there was very limited access, some HIPAA compliance issues that we needed to kind of work through, that kind of thing. Our registry reports indicated that our long-term follow-ups were in the teens. We ended up going through a period of probation just because those scores were so low, and we were like, okay, it's in the teens. We have got to figure this out. So unlike what Betsy said about keeping things realistic, we said, okay, we're going to go from the teens to about 90%. That's what our big goal was. We were like, there's no point in shooting low. We wanted to shoot high. So our approach was very multifaceted, looking at both of the physician groups, trying to figure out what the individual barriers were across each one of those. Expectations to meet the guidelines, you guys know what those look like. So I'm going to kind of skip over that. I know we've got time issues. Milestones, this was not a short-term project. So we started looking at this probably around 2015, trying to figure out exactly what we wanted to measure. We expanded our registries at that time. We had originally started out with only cardiac or carotid surgeries. So we expanded that. The Aortic Center was thrown into the mix. Of course, that gave us more patients, more physicians to work with. One of the big problems that we had is we didn't have a dedicated data abstractor. Michelle was added into the mix in 2018. That created a phenomenal opportunity. If you don't have a dedicated data abstractor, you have to have one. We also started looking at quality a little bit differently, which is where my role came in as a clinical nurse specialist. We did not have a dedicated quality person for vascular surgery, so that made a big difference as well. The probationary period happened in August of 2019. Since then, Michelle has gained access to the Jefferson Surgical EMR. She's able to work remotely with those. It used to be people would have to drive over and literally sit with an IT person to comb through charts. We managed to come off of probation that same year, which was pretty impressive. And then our long-term follow-up by March of 2020 was up to 89%, so we were very, very proud of that. For teens to 89%. This one, yeah. Is this one? So we did a deep dive into different barriers. Situational awareness was big. We have a vascular interdisciplinary quality council where we do a quarterly update, kind of making sure that there's ongoing situational awareness as to what our projects are and what our goals are for those. We do have both of the physician teams that join in that meeting.
So I start reviewing our records at the 9-month post-op from an Excel spreadsheet that I created with the goal of reaching out to each office for patients that didn't have a follow-up scheduled at the 18-month mark to get them in before the 21-month period closes. I also created a smart phrase template for the offices to use for phone follow-up visits that can also be modified for in-person visits. This is an example of my spreadsheet. As you can see, in green is the 9-month opening. In yellow is the 18 months to give me, hey, these patients need to be seen, and 21 months is the closing date. I also have places to document notes, date last checked, if the patient is deceased and why no follow-up is possible, and also who they were seen by. Both smart phrases were created from our long-term follow-up forms so we could gather as much complete data as possible. We did combine CEA and CAS because they do share a lot of the same data. And this is an example of our Endo AAA form that was also created from the long-term follow-up form. In 2014, we were at 14% compliance due to lack of access to Jefferson's EMR. But after gaining access in 2019, I was able to go back and work on getting 2017 and 2018 rates up to get us out of probation. We did see a little bit of regression in 2019, down to 85% from the previous 89%. We did a deep dive that led us to learn that 2 of our physicians had left and realized some of their patients had been lost to follow-up. We gained access to Jefferson's EMR in 2019, so that gave me access to their follow-ups. Due to the Stark Law in Virginia, I'm not able to call Jefferson's patients. Therefore, it leaves it up to their office staff to do phone follow-up visits. In February 2017, the aortic center opened, and that increased its number of patients that we abstract for. As new employees are hired, we will make sure to communicate what we need to keep our long-term follow-up compliance going in the right direction. With us covering patients from rural areas, it is sometimes hard for the patients to travel such a long distance for the follow-ups. So this has also increased since COVID. As with the entire world, COVID-19 has made it harder for follow-ups with patients due to staffing shortages, scheduling conflicts, and patient fear. This has led to an increase in telemedicine, and phone follow-up visits have been increasingly important. Since starting the center, the charter information sharing between offices, Suzanne and myself, has increased greatly. We have added CVI Gold to this year's to give ongoing awareness to leadership. Having established contacts at both offices have increased our success in catching appointments that might otherwise be missed.
So moving forward, sustainability has kind of already been a conversation here today, but we know that this is going to kind of be an ongoing project that we're probably not going to be able to really drop. It's going to have to be something that we're constantly reporting out on at our quality council meetings. We are having continued efforts with both of the physician teams to make sure that they have awareness, make sure that they're going to sustain the outcomes. The aortic center in particular is growing leaps and bounds. We've actually added 4 new mid-levels and another surgeon just since we launched it. So it's a lot of education for the new staff who are coming in. We want to make sure all of our stakeholders are aware of what our expectations are. So we're giving those in quarterly updates to the surgeons. We're also doing an annual process review, looking for new barriers because, as things constantly change in facilities, there's always new barriers to identify and try to work through. So we're doing an annual review for changes and barriers to that. One of the other things that we did add is we added this measure to our CVI scorecard measures. And so that helped escalate it up our chain to be something that was going to be looked at across the system when we do like our overall quality reports for the hospital system. Thank you guys for the honor of your time. If you have any questions, let us know.
We'll hold questions till the next speaker's presentation. Our next speaker is Ritu Karki Sitala, who has a master's in nursing and has over 4 years served as a VQI nurse analyst for UC Davis Hospital and Vascular Institute. She has had multiple VQI projects over the years, including last year with discharge medications as one of a poster abstract. Her topic today will be Quality Improvement Project and Long-Term Follow-Up for Aortic Sac Diameter Reporting on EVAR and TVAR patients.
Thank you, Gady. Good morning. I'm Ritu Kargi from UC Davis Health from Northern California. And today I'm going to present our QI project on long-term follow-up with a focus on sac diameter reporting on EVAR and TVAR patients. As we all know, regular long-term follow-up for the vascular surgery patients is crucial to ensure the treatment success, and for the EVAR and TVAR patients, this includes sac diameter reporting. Our VQI data showed the long-term follow-up was 67%, and the sac diameter reporting upon long-term follow-up for EVAR was 38, and TVAR was 55, according to the biannual fall report 2020. So we decided to work on it and established a goal to improve the percentage of patients receiving the long-term follow-up 9 to 21 months post-procedure, and the goal to improve the sac diameter reporting for the EVAR and TVAR was also established. In the effort of the improvement, we implemented various strategies, including improving the existing workflows, implementation of the smart phrase, constant communication and the synchronized workflow, phone calls, and the video visit. Improving the existing workflows. Existing workflows were evaluated by all the stakeholders, including vascular quality team, vascular providers, vascular clinic nursing staff, and the standard workflow was developed. Initially, the quality team would register the eligible patient in the pathways and update the specialty notes section in the EPIC to communicate with the clinical staff about the patient's inclusion in the VQI and the time frame they need to be scheduled for follow-up. The note in the specialty notes section were referenced by the clinical staff, scheduler, and the physician. Implementation of the smart phrase. The smart phrase was implemented for the physician to document the required long-term follow-up fields. Smart phrase also includes the sac diameter data fields for EVAR and TVARs. Constant communication and the synchronized workflow. Constant communication between the team members and the synchronized workflow played the important role in improving the long-term follow-up. Shared Excel sheet was utilized to track and tackle the outstanding long-term follow-up cases between the data quality team and the vascular clinic staff. Progress of the project was communicated within the team regularly. Personalized phone calls. Our aortic nurse coordinator worked as a team member and followed up with the patients who were not able to do our on-site visit. While calling those patients, all the demographic-related data were collected utilizing the smart phrase. Sac diameter imaging were retrieved from the outside organization, if done any, and reviewed by our physician. So as we can see, our percentage went from 67 to 80s, and for the TVAR and the EVARs, it went up to 90s. So during the process of the workflow improvement, many challenges were faced and many lessons were learned. Initially, bringing all the team members together and allocating the time was challenging. Since many of the team members were new to the VQI registry, proper guidance and education was important. Patient compliance for the on-time follow-up has still been an ongoing challenge. The smart phrase documentation from the physician and the residents definitely took a lot of effort. Despite of all the challenges and the hurdles, the diligent work from all the team members paid off. During this period, constant communication and the multidisciplinary involvement were one of the many success factors for our project. I would say it was possible because of the team effort. I would like to thank you all the contributors who were involved in this project directly and indirectly, and a special thanks to the Dr. Matthew Mail, who is the Chief of Vascular Surgery in our center, who helped in this project by facilitating and taking the lead. Thank you.
Thank you for staying on time. We'll have about 3 to 4 minutes for any questions. Dr. Jorgensen, you start off.
Those were two more very impressive presentations. And one thing I just want to point out is this is not just a matter of making the numbers look better. This is improving care. And so that's really terrific. Michelle, I have a question for you. On your follow-up, you had the patients in green at 9 months. And sort of in reference to Dr. Coogan's question earlier, how do you identify those patients?
I actually put the patient right after I abstract their data. I go ahead and put them in the Excel spreadsheet, put the date of the surgery, and I have it calculate the exact 9-month from the reference that's given by VQI.
Mm-hmm. And my understanding is sort of a question for the FIVOS group is that I think there's a method to identify patients who are due at 9 months for follow-up. You can print out a list. Can somebody help me out and expand on that? Or? Mm-hmm. Okay.
You're yielding? We're getting an answer coming up. Okay.
Yeah, so in the VQI, there is a long-term follow-up report. It's a procedure records requiring long-term follow-up. You can specify the time frame that you want to look for and the window of follow-up that you want to identify. If you're doing something maybe outside of the standard, you could do that as well. Or you can do your 9 to 21 months to meet your VQI 1-year requirement. And that will generate a list of any follow-up that still needs, or any procedure record that still needs a follow-up for that time period that you've run it for. So we don't have a proactive push, but there is a way to pull that data on a regular basis.
Great. Thank you very much. And I think if there are any further questions to contact Pathways. One other comment that I wanted to make is that, many of these are great ideas, great projects, but always what follows is diffusion, getting your message out to everybody, and then sustainability in reference to it earlier. And so I think as you develop these quality charters, to think about that, to think about diffusion, and to think about sustainability as you write it. Thanks very much.
Just real quick in reference to the spreadsheet that Michelle sends out, I think one of the things that really does help the offices with identifying patients is the stoplight format that it's in. That stoplight format it's a simple visual, but it really does seem to make, I don't know, more of a sense of urgency of, hey, this one's really coming down to the end of the line, and it encourages the office staff to help us with getting those patients in quicker.
Mark Ifray from Vanderbilt. A question for the Carillion group. So I was intrigued to hear that you found, or you felt that the Stark law was a problem. Yep. My understanding was that the organization of VQI from the outset and the evolution to a PSO was designed to make it not a problem. And I know there are many sites that have multiple groups working through the same facility. So are you convinced that that's an accurate reading of the Stark law? Because it's not a state mandate, it's a federal law. Or is there something special going on that you're trying to deal with?
So when our legal team was looking at that, they felt like that was going to be considered an enticement if we were doing those follow-up phone calls for them. So it was something that was kind of handed down from our legal team that they did not want us doing.
Thanks.
Hi, Sandy from Yale New Haven Health, and both projects are awesome, and long-term follow-ups were one of our struggles and continue to be a struggle for us. This is more of a question for VQI. For the long-term follow-up, we are collecting data for follow-ups from any provider. Why is that? Why is it not focused on vascular providers? Because what we then did is we created a dashboard that just focused on our vascular providers, and we have that data. Obviously, it's less, but it's important for us.
So as to who provides the follow-up, so I'm just going to use an example of EVAR. So if I have a patient that I've performed an EVAR on, so let's say they're within the window, but they saw their cardiologist for some other reason, and he did an ultrasound in the office and had that. So what's important is that we are tracking the patient, not necessarily who's actually, who's doing it is less important that it's getting done. So that's why we really don't, it's agnostic as to who provides that information. So, and some of it also we found helpful during, when COVID was bad locally, was we would do more via telemedicine, and we had actually a really good working relationship with some of our primary care groups they had nurse navigators who would help the patients with their telehealth for that visit. So they would reach out and say, hey, do they need anything when we see them? Be like, look, if you have an ultrasound, that's great. And they would just then send us a note saying that we discussed it with them, this was the ultrasound, do they need a separate visit with you? And it would, from a patient's standpoint, it may reduce their visits, and especially given a lot of the age of our patient population. And for us, parking's always an issue, and travel into the city. So anything we could do to make sure that our patients get the care and don't feel overly burdened by it. So I hope that answers the question.
Yes, it does. It just, if a patient's followed up by ENT, and then we track it as compliant. We just feel like that's false information for us.
Yeah, so I think it's, and I think it's interesting. I always assumed that, of course, I see every single patient back. That's good medicine, right? And then when we look at it, it's like, ooh, no, I don't. I think that the awareness helps us in the long run. And again, it depends on what we're interested in. So I'll be honest, after an EVAR, I am most concerned that at least I know about the imaging, whether I see them or not. So long as I know that that sac isn't growing, so long as I know that that graft hasn't migrated, that is much more important to me than me having, touched that patient again. So I think thinking about what the overall goal is, yes, the more interaction I have, the better relationship I have with the patient, the better care I think they get overall. But the patient's time is also a limited resource. So I think we get it where we can.